Dr. Kanisham, should we start?
Yes.
Okay. Namaste to all the participants, panelists, and the viewers. My name is Chandrasekhar Koneru. I'm a physician practicing internal medicine in Huntsville, Alabama, a trainer of Heartfulness meditation practice. It gives me a lot of, the joy to invite and welcome all of you on behalf of the Heartfulness Institute. And to this, especially, in these times of crisis, to continue this educational series. As we have seen, in the last couple of talks by the distinguished speakers, they were very well appreciated and received by the physicians both in India and US. So today we have a talk about antivirals and antibiotics in COVID by Dr. Rahul. And this program is organized in collaboration with Medicover Hospitals and the Association of Physicians of Indian Origin. This is American Association of Physicians of Indian Origin. So Dr. Ganesham, Dr. Ganesham, who is the intensivist in Medicover Hospitals, is going to take over and he'll be moderating these sessions. And now I hand over to Dr. Ganesham, and he's going to introduce the speaker, panelists, and other participants. Thank you.
Thank you, Dr. Chandrasekhar. And welcome, friends, to the third topic of this webinar. I hope everybody is doing well. Well, it's heartening to see the numbers coming down, but they have not completely disappeared. And I think we still have to be careful. And in continuation with the last two topics, today we are going to discuss a very, very important topic related to the management of COVID, which was extensively debated, dissected, not only in a lot of medical journals, but also on various national and international media. 1 year down the line, we are still grappling with the precise indications, timings, roles, and durations as far as the role of antivirals and antibiotics are concerned in the management of COVID-19. To take us through this, I have my dear friend, Dr. Rahul Aggarval, who is a senior consultant physician with me at Medicover Hospitals and who has been involved extensively over the last 1 year in managing COVID patients on both as an outpatient as an inpatient basis. And I have with me a team of very distinguished panelists, Dr. Atul Gogia, who is a senior consultant in internal medicine and infectious disease at Gangaram's Hospital. Welcome, sir. Dr. Naval Chandra is an additional professor and unit head, Department of Internal Medicine from the Nizam's Institute of Medical Sciences. We have Dr. Kunal Desai, who is a specialist in infectious diseases from South Dayton Acute Care Consultants, and he's also a member of the Heartfulness Foundation, which has been instrumental in getting this program live to us. And lastly, my dear friend from intensive care, Dr. Manish Bharti, who is a consultant and intensivist in charge from Prince Sultan Cardiac and Research Center, Saudi Arabia. Over to Rahul.
Thank you so much. And it's a pleasure and honor to be able to present a slightly, what we call as half boring, half important topic that we should be aware during this COVID times. I hope I am visible. Hello?
Yeah, good.
I am visible.
Yes,
okay,
yeah.
now. So what my topic today would be is about the role of antivirals, and which we have loads of them, and antibiotics, which we use loads of them in COVID-19. So I am Dr. Rahul Aggarval. I am a senior consultant physician in Medicover Hospitals, Madhapur, High-Tech City. And this is what we are taking you through a journey. I would be a little extensive, if you may permit me so, because I wanted to be very short and sweet, but it wasn't short, neither sweet. So this is a simplistic structure of the SARS-CoV virus. The very fact that we can make it simple structure makes it that dubious to be treated. You can treat a bacteria, a fungus, you can treat a parasite because of the sheer size of it, and because so many structures are involved in it, so that we can target one or the other in some enzyme, some wall or something. But this RNA intelligent virus, and a very shrewd one, has got very few things to give us target upon. So most of the antivirals, in fact, are not in the true sense antiviral. They don't kill the viruses. In fact, they are anti-host defenses. So they will mostly target upon the what the host does to the target. So uh, there are possible targets of antiviruses that I would not go into very deep details, but you can see there are certain that helps in the membrane, like baricitinib, like umifenivir, like chemostat, and then there are certain that will decrease the transcription of the viruses, and then there are certain that helps in decreasing the cytosis of the viruses. So there are certain drugs of medication, classes of medication that we can use, that we have been trying to use. And apart from all these antiviruses that we are able to see in this slide, there are certain antibiotics that have antiviral roles, and recently certain chemicals like 2DG that has got antiviral roles. There is a very short antiviral window, if I may say so. Too early, too late, we are nowhere. So there is a prophylactic where we can give an antivirus as a prophylaxis. There is an antiviral window where we actually can give the COVID virus medication. You can see there is no prophylactic medications. After the exposure to the SARS-CoV virus, also it takes some time, like a week, for the virus to reach its peak levels in the blood, and then only we can start the therapeutic window. So this is what happens, that even after the infection, the live virus can be isolated only usually in the first week. After that also you can have viral persistent RNA, but it will not be able to be isolated in the first week later. Similarly, all the antivirals that have been showed best possible activity in the laboratory conditions have shown in the replicative phase of the viruses. And as studies show, this window closes by as early as the 8th day. Mind you, after that, antivirals may or may not work. So beating around the bush after the snake has gone by is of no use after that. So they are not directly involved, as we know, the viruses. It is after the virus has gone, the serious disease starts. Then only the um, problem starts with the dysregulation of immune system. So targeting viral replication when the dysregulation system starts is of no use. There should be ongoing trials that should actually focus on the initial part of the viral activity and try to find out its role, whether or not in the initial phase the virus is killed or not. This is what is the initial thing that they should do while trying to start a trial. Later, nothing works. So these are the tried and busted, as I may say so, antivirals, antimalarials, antibiotics, and whatnot that have been tried, but have so far, excepting remdesivir to some extent, and ivermectin in a yes or no way, otherwise not been so fruitful. Is there anything that can prevent or have a pre-exposure prophylaxis? Nothing like that. This is the NIH guidelines that says that there is no such medication that is available. There are certain agents which we can use, but they are still under investigations, and so far very discouraging results have come. Is there anything that is for post-exposure prophylaxis? Again, there is nothing. And of course, it recommends highly against the use of hydroxychloroquine as post-exposure prophylaxis. I used to take prophylaxis of hydroxychloroquine for about 4 months in between when we were in the first wave, but I have since stopped. So there is very limited data that ivermectin could be either used as a pre or post exposure prophylaxis as of now. The UK government has tried to find, and it is made a task force to find out anything that can be used in an OPD basis by autumn. So this is a small article in the BMJ. They have found disappointing candidates in our favorite favipiravir, our azithromycin, in fact, nitazoxanide, chemostat, one TMPRSS2 inhibitor, apilimod, PIK5 inhibitor, and of late, molnupiravir have shown some progress, some promise. We come to the hero of the day, that is remdesivir. So this is a trial that was started by the WHO consortium. It was to find out whether really remdesivir was working in patients. So they took 30 countries in all, 405 hospitals, and close to 11,266 participants, and gave them different medications that were at that time available for the COVID-19 treatment. Of those, 2,750 patients were assigned to receive remdesivir. I'll tell you the results later in a comparative study. So what exactly is a remdesivir? Is an intravenous prodrug that is converted into an active form on administration. It binds to the viral RNA-dependent DNA polymerase, actually causing premature termination of the RNA transcription. So it doesn't actually prevent the binding of the virus to the AC2 receptor. It works afterwards. So it is the only FDA approved antiviral at present as of now for adults, for pediatric patient more than 12 and weighing more than 40, and has had an emergency use authorization for the treatment in patients weighing 3.5 kgs and weighing more than 3.5 kgs, meaning it's just an emergency use authorization. It is not actually approved. It has to be administered in a hospital where the healthcare setting is present, or sometimes we give it when we were in the peak of the this epidemic. There were people who were in healthcare settings which were given remdesivir, but it should be given in those conditions where you can have an inpatient type of care in the setup, be it a quarantine center or whatever. Then what is the rationale for the use of remdesivir? There are certain trials that say yes or no about it. What is the most robust trial that FDA used to approve its remdesivir usage was the ACT-1 trial. It enrolled about 435 patients, and they saw that there was an improved time to recovery in patients who required oxygen supplementation, but they did not require very high oxygen demands. Similarly, at the post hoc analysis, deaths by day 29, remdesivir appeared to have substantial benefit in those who had actually requiring high flow oxygen or ECMO or mechanical ventilation. So somewhere remdesivir was working best in those who had low oxygen demands, but also in some way worked in those with mechanical ventilation, high oxygen demands, and ECMO also. But on the other hand, the solidarity trial that was done by the WHO showed no difference of in-hospital deaths or even the outcomes in those who received remdesivir or not. So what they have essentially done is they have taken out remdesivir also from the armamentarium that we were having for COVID-19. Since Solidarity is an open label trial, it is having a lot of say criticism in terms of its interpretation of results. And because the study design was such that you had to give remdesivir for 10-day course of therapy, there could be that the patients were delayed in order to complete the therapy also. So there are also all ifs and buts. So the cumulative data at present says that remdesivir is effective, very so, in a best possible situation in which the patient is requiring just a little bit oxygen, but not in a very high demand. And then there are certain special circumstances. What would you do if a patient is coming with moderate COVID-19, but doesn't require supplemental oxygen? There is insufficient data to recommend or to refute. You can use if you are having a patient who is having very high risk of disease progression. Similarly, if somebody is on oxygen, high flow, but not on invasive mechanical ventilation or ECMO, there is an unclear recommendation. You can use, you cannot use is still not a very clear-cut clinical benefit. Of course, you should use remdesivir along with corticosteroids in these patients. And in rare cases, if corticosteroid is not available, baricitinib can be used. For patients who are hospitalized and on a mechanical ventilation and ECMO, remdesivir should be continued till the treatment course is completed. And this is along with dexamethasone or other steroids compatible that has to be continued along with remdesivir, not as a monotherapy at all. So what are the guidelines saying so? NICE guidelines says consider it in hospital settings, in patients who are needing low flow oxygen. IDSA also suggests you can use it in hospitalization with severe also, rather than using no antiviral treatment. If somebody is on ECMO, you can prolong it as much as 10 days. If not, 5 days is enough. But those who are having good oxygen oxygenation, like 94% and more in room air, you should not use remdesivir, is what IDSA says. What does the Ministry of Health and Family Welfare say? That you can consider it within 10 days of onset of symptoms, again during the viremic phase in moderate to severe disease, who are requiring supplemental oxygen. Unfortunately, WHO, barring a very small subset of patients, so that is in inverted commas, they have a conditional recommendation, but more or less it says so that throw remdesivir out, we are done with it, we are not going to use it. A brief about this ACT trial. It is a multinational placebo-controlled double-blind trial that was done by the US FDA, and it showed that there was a reduced time to clinical recovery. It was benefited in most to patient hospitalization on supplemental oxygen. There was no observed benefit in patient with high flow oxygen or on mechanical ventilation or on ECMO. The problem with the trial was that there was a wide range of disease severity. You were not powered to detect differences between the each subgroups. Similarly, there was no mortality evaluation was done. Also, there was no long-term morbidity evaluation done. Of course, the trial showed such a good benefit that it is still the reason why FDA has kept as a FDA approved drug the remdesivir only antiviral for COVID-19. This one, that is the black dot for remdesivir, was an open label, multi-international trial, taking a lot of patients in a lot of centers across the world, and it categorically told that it remdesivir did not decrease the in-hospital mortality in hospitalized patient when compared to local standard of care. Problem was, it's an open label study. Second was, there was no data on time from symptom enrollment to the onset of symptom to enrollment. Similarly, there was no assessment of outcome after the patient got discharged. Then there is a study that sees whether or not remdesivir is good enough for moderate COVID-19. It was seen, this is a Chinese study, no, it was in JAMA. It was that it had better outcome, but of uncertain clinical importance. That is a very difficult to interpret line. But what I get and what we do it in our clinical practice is that we offer remdesivir to moderate COVID-19 to the people who we suppose that they are going to crash or go into higher oxygen demands, or if they are not on oxygen, they might require oxygen. That, in my humble thoughts, is those who are having bad lungs on radiology, those that are having increased inflammatory markers, or those that are having um, comorbid condition that might land them in from moderate to severe category. Then there is remdesivir that was uh, uh, seen in China to see in patients with severe COVID-19. Although they took a very small number, 237, they found that there was no difference in time to clinical improvement, 28-day mortality in treated and untreated patients. Again, there was a lot of other medications used like corticosteroids and antivirals, interferons, that could have obscured the effect of remdesivir. So we cannot specifically say if remdesivir does not work in severe COVID-19. Then there is another study that specifically sees what is the duration that we should give remdesivir, because it was sometime postulated that you give 5 days, sometimes 10 days. So this study found that there is no difference between 5 to 10 days and has shown similar clinical benefit. But I still stick to what the FDA has told, that if you see a patient on minimal oxygen demand, start for 5 days. If you see a patient on severe COVID requiring mechanical ventilator, then you can continue for, or ECMO, continue for 10 days. There is a talk that I would want the panelists also to answer me later on. What if the patient is clinically fit to go, but we have not completed the remdesivir course? Or there is a talk that remdesivir can be given for 3 days only. Is it okay or not? I would want the panelists to please answer my question. The treatment protocol is that you give it as an IV for 200 milligrams stat followed by 100 milligrams over day 2 to 5 for those who are not on mechanical ventilator, and you can extend for 10 days for those who are on mechanical ventilator. Of course, there are adverse events that you need to keep in mind, specifically AST and ALT elevations more than 5 times. In some places, I've read 10 times also, that you need to stop it. Similarly, the drug vehicle is SVECD, which might cause renal toxicity. So you should be little aware in patients with moderate to severe renal impairment. Of course, it is not given or recommended in EGFR of less than 30. We can give, in fact, in those who are having EGFR of 30 and less. In our hospital, we have given and found that not too many people have worsened also. But then that is again open to debate. And drug-to-drug interactions, it should not be mixed with chloroquine or hydroxychloroquine, that is period, because the antiviral activity will be decreasing, not recommended. Now we come to one more molecule that has in recent times gained a lot of attention, that is ivermectin. NIH says that there is an insufficient data to recommend either for or against the use of ivermectin. IDSA says that you can use outside the context of a clinical trial, you cannot use it. But Ministry of Health and Family Welfare, in its latest guideline, has also included it in the mild cases. One thing about ivermectin is that there has been a meta-analysis of 56 trials that has been done. It has shown that it has got significant benefits in most of the cases across the world. In lot of studies that have shown that ivermectin has got a definite role in the treatment of COVID-19. Again, that is open to debate. Then comes another one more culprit, I could say, is the chloroquine or hydroxychloroquine with or without azithromycin. FDA initially told that, yeah, we were fine with the chloroquine as an emergency use authorization. In March 28, it was again revoked in June 15th, 2020, that no, we don't want chloroquine in our life for COVID-19. The reasons were manifold, because of a lot of side effects, because of a lot of dubious results of it being good or bad for COVID because of a lot of arrhythmias that were encountered and drug-to-drug interactions. NIH recommends against the use. IDSA recommends against the use. WHO strongly recommended it against for any severity of COVID-19. Ministry of Health and Family Welfare still gives it in mild cases of COVID-19. One of my another favorite is a favipiravir. It's a prodrug, and it helps to inhibit the RNA-dependent RNA polymerase of influenza and other RNA viruses. It has in vitro activity against SARS-CoV-2, and that is the reason why it was initially given. And a lot of hospitals across a lot of countries are in fact still continuing to give favipiravir. That is including Sri Lanka, Pakistan, and Russia, and Japan. These are the places where favipiravir still is used. Singapore, where it is still used in the treatment of COVID-19 as an outpatient basis. So still, I would like the panelists to tell me favipiravir whether or not it is still to be used or not. There was this drug that actually came into limelight for a very small, like one film wonder, lopinavir, ritonavir. It was initially touted that you can give it to even pregnant females in the second trimester, and this that. Again, despite its theoretical action on CL Pro, it was removed from the NIH and the IDSA guidelines. Ribavirin, that was a very old medication that was supposed to have a broad spectrum antiviral activity, has now been not recommended in any, not even mentioned in a lot of recommendations. So IDSA says that the only in vitro evidences are there, and they are inconclusive, and some of them might show that there are some possible harm, so better stay away from it. Again, oseltamivir, which is used a lot in our Indian setup for H1N1, has shown by IDSA that it is unclear whether the mechanism of action of oseltamivir will favor anything to it to act against COVID-19. There was a time in last year when we had few cases of H1N1 and COVID-19, in which we are perfectly justified, but as such per se, just for COVID-19, the question mark still remains. Then there are darunavir and nafamostat and chemostat. I would want to talk about chemostat, which is a serine protease inhibitor, but it is an orally available antiviral, possibly has some role in the OPD basis treatment. Possibly, if a lot of trials are done elsewhere in say post exposure or in the OPD basis, it could have some role. There was this umifenovir, which was also touted initially as having SARS-CoV activity, but in a meta-analysis that was again thrown out of the window. There is no evidence to suppose its use. I would want to talk about a small molecule called as molnupiravir. This molecule is perhaps the only molecule which we are actually having at present as an oral medication for RT-PCR positive COVID-19 patients. There is an ongoing trial that is placebo-controlled, double-blind, and multi-site that is evaluating its efficacy. What is the initial response is that there is a greater decrease of baseline viral RNA in COVID-19 patients at day 5 and day 10, and undetectable viral RNA at day 10 and day 15 following the treatment. It was also started for an inpatient like move-in trial that was stopped because there was no benefit. The final data would be available around September, October in 2021. We hope and pray to God that molnupiravir should, in 800 milligram thrice daily dosage, be able to answer our quest for something that is available as an oral antiviral. There is another one more molecule that is, these are, I'm talking about the newer molecule that are in the pipeline. It's a PF 0732132. It is the only first orally administered COVID specific investigational protease inhibitor that is studied by Pfizer, and it is in the phase 1B multi-dose study. We will get the results and probably let us know if at all. This is also another one more molecule that is as promising as molnupiravir. Then there is a plitidepsin. It is a molecule that is derived from Apelidium albicans. It has antiviral activity, which is supposed to be 27.5-fold more than remdesivir. What the guidelines say, in any of the guidelines, it is never even mentioned. But of course, we will have to wait and see. And it has to be that Virat Kohli that will come out once we have done with Sachin and Rahul. Apilimode is a inhibitor of the interleukins, that is an anti-inflammatory. It is in the phase 2 randomized controlled trial, and we will see once the report comes whether or not it also stands the time. There are two antiviral candidates that are PF 008352331 and 8527 that also are in the pipeline. But all these, right now, there is insufficient data, and we are just waiting, hoping, praying that some of these molecules, whatever the way they act on the virus or the host, help us a way out. I want to talk about a very important thing, that is antibiotics usage in COVID-19. There has been a rampant, irrelevant, unnecessary, irrational, and loads of use of antibiotics. The problem is of a virus, and the beneficiary is an antibiotic pharmaceutical. Not even in India, if you see in China, as much as 58 to 95%, in Spain, as much as 74%, and New York, as much as 65% people used antibiotics. And there is no actual data that tells that there is a co-infection of COVID-19 along with a bacteria for any community-acquired pneumonia that we see in a patient. Even in the patient who is having a high risk, like those with COPDs, like those with earlier lung disorders, or those with the immunity that is low, including diabetics, the reason to panic and start antibiotics is not there, because the co-infection between a bacteria and a virus in the same individual is very, very less. In the New York study, it was found that only 3.8% had a dual infection, that is a bacteremia and a viremia. And in those subset, if you remove those normal natural commensals, it came as less as 1.6%, which probably is there in which any cases we see as an outpatient basis. All the guidelines do not support the use of antibiotics, be it NICE, be it Ministry of Health and Family Welfare, or WHO. In fact, WHO told that you use moderate COVID-19 antibiotics, but if there is only a clinical suspicion of bacterial infection. Panelists, please help me out. When do you use antibacterials in your case? Antifungals we'll talk in some later talk again. I want people to answer my question is, when do you actually start an antibacterial in a patient, and for how long, and whether it is indicated post discharge also. One of the antibacterials that we are been using left right is doxycycline. It is a semi-synthetic derivative of tetracycline, bacteriostatic in action. It also has, other than its antibacterial action, it also has a pro-inflammatory action. It modulates the pro-inflammatory cytokines. General use is not recommended unless there is a real infection that we are thinking about doxycycline. Again, ticoplanin is a glycopeptide antibiotic, which probably has some role in SARS-CoV-2. The trial done was in a French cohort of only 21 people, and then that was not very, very conclusive. Although they say, yes, we have some role of antibacterial role of ticoplanin. I'm sorry, I don't know why that slide of 2DG could not upload in this. I want to talk a little brief about 2DG that has come into picture nowadays. 2DG is a joint effort by the Ministry of Health in India and our DRDO in Hyderabad. So there is this joint effort that has come up with a old molecule that was used as an anti-metabolite and cancer cell that was supposed to act on in rapidly growing cells and kill them, because 2DG is a non-hydrolyzable form of deoxyglucose. So it cannot be hydrolyzed. So it stalls the glycolysis then and there in the cells. So the cells can't take their oxygenation and they die. Also, it has got some role in the receptors of the viruses, specifically SARS-CoV-2, which has been postulated, and that is the role. That is the reason why a clinical trial is underway at present that thinks and talks about the role of 2DG and its antiviral effect. The data that was done was sufficient enough for the Indian government to use it as an emergency use authorization for as an adjunct treatment for COVID-19 patients, along with the standard medical care that we give. It is given as a 45 grams of powder, 45 milligrams of powder per day in 2 doses, and it is to be diluted properly. And then there are practically no major side effects that they tell. And this is another area I want our panelists to discuss about the role of 2DG and how they want to use it in the near future, given that there is not too much of a randomized controlled trial data upon it. Similarly, one word about remdesivir in pregnancy. Again, this year we have seen loads of patients who are pregnant and have gone bad with SARS-CoV-2. Remdesivir, according to what the gynecological guidelines says, so that it is only to be used if the risk outweighs, if the benefit outweighs the risks, and it can be given in any trimester, but more safely so in the later trimester. Also, that it has been used remdesivir in patients, pregnant patients who have suffered with Ebola viruses, and has had not too much of a adverse outcome in the pregnancy or even in the child. So probably there is healthy data for the use of remdesivir during pregnancy. So with that, I would want to thank all of you to giving me opportunity, and thank you so much.
Thank you, Rahul, for this very extensive and elaborate overview of the various antivirals. To be very honest, I never knew that there were so many drugs which are available and which have been tried. And good that the media didn't know that, or else we would have been facing much more difficulty in treating COVID patients. Can I have all the panelists with me? Dr. Atul.
Yeah.
Kunal. Yeah. Dr. Kunal. So basically, I just want to start the discussion, by asking this one question to all of you, especially in a country like India, after 1 year of the pandemic, where we have seen shortages of bed, where as clinicians and physicians, you would have seen a large number of patients on an outpatient basis, or a lot of calls regarding what to do with respect to the use of antivirals, both as prophylactic or in milder cases. What is your stance, especially since the Ministry of Health still recommends the use of hydroxychloroquine in the milder cases and ivermectin? Dr. Atul, Dr. Nawal. Rahul, you also can give your views.
Good evening. It was a very extensive presentation, and he covered up every point, and I'm sure that all of us here has probably used most of these drugs in our journey over the last 1 year, and we have seen the ups and downs of all these molecules, and there is a lot of debate about, always has been, about HCQS and ivermectin, and they being relatively cheap drugs, easily available, have been tried for so long, so we try to repurpose these drugs. So all of us, I'm sure, have used this as prophylaxis, treatment, both HCQS. But of late, I think during this latter half of the first wave, after the after initial 6 months or so, probably HCQS has probably gone into disrepute for whatever reasons. But the usage, although it is there in Ministry of Health guidelines, but not many people are using it. We are not using it right now, and the prophylaxis also, once everybody in the healthcare setup are getting it, so the prophylaxis thing also went off. And so HCQS probably did not catch up, although it had, for the initial 6 months or so, because there were no any drugs, and this was one which was easily available. So probably we're using it, and there was always this concern about arrhythmias and drug interactions and things. Going on to ivermectin, which is still very popular, and I'm sure everybody has used this, and we have also used it in mild cases. But still, I am not very confident whether it is effective or not. But it is there in the guidelines, and it is there all over, and certain states have, brought out the guideline that it is being used for prophylaxis as well as for treatment. But ivermectin, we are all using it. Generally, it is well tolerable. People are not having much of a problem. How much benefit it is offering, I'm not very sure. But I feel the mild cases, most of them, it is their immune reaction and supportive care which helps, rather than any of these drugs, whether it is doxycycline or ivermectin, which would work. It is only that it is just like, you have to offer something to the patient. It is more of that, rather than, you don't offer it, somebody else would. And now everybody is, wiser. The patients are wiser these days. They have all the information from WhatsApp. Okay, Dr. Sahab, ivermectin ही नहीं लिखा आपने, ये तो main दवाई है. So it is that way. So that's what it is about these drugs.
Rahul, sir.
Yeah, I agree totally with Dr. Atul. As we all are aware, the guidelines have evolved over the last year. When we first started treating our COVID positives, we were stressing so much on HCQ, ivermectin, doxycycline, being a very, very important aspect of management of COVID. But as guidelines evolved, though the Ministry of Health does recommend, as Dr. Atul says, even in our day-to-day practice, we have stopped using any of the HCQ formulations, and so much so even doxycycline now. Only molecule we continue to use is ivermectin. And as what Dr. Atul said, I totally agree. If you ask me why and how and what studies are substantiating my usage of these, I still haven't, I wouldn't be able to give you the right answer. And I'm sure neither of anybody of my colleagues would, because it is an evolving disease. Everyone is evolving with the disease, and we are all learning as time goes by. So there would some molecules without a reason being used, and some molecules with more and more evidence coming up being put into these guidelines. So as long as these two molecules, I think, I would.
So my take on this too, this ivermectin and chloroquine, my take would be we have not see them as an antiviral. We have to see them as an immune modulator.
Yeah.
Chloroquine we have been using so many times for rheumatoid arthritis, SLEs. We take them as an immune modulation, not for antiviral activity, although some in vitro activity has shown that they are antivirals also. Similarly, ivermectin, I have a strong this thing that Indian specifically, or South Asian subcontinent specifically, have a lot of GI dysregulated immune system. Probably killing those germs, probably that is why nitazoxanide, which I did not add up in this. Nitazoxanide or some anti-helminthics have some basic role, if not as an antiviral. In some way, they will increase the gut immunity to the favor of having a better regulated immune system than getting it into dysregulation.
Okay. Manish, any thoughts? We are in a way lucky because most of our patients are not in a position where once they land up in the intensive care unit, they are outside the realm of either hydroxychloroquine or ivermectin. But I'm sure as a doctor, and you would have got calls from friends, families, probably those who are still not in condition where they need to get admitted, but we still do end up prescribing something for them. As Dr. Atul put it, sometimes you just have to play with their psyche. Is it just the psyche which is playing there, or do you really think there is something working?
Dr. Manish, you need to unmute.
Yeah, thank you, Ghanshyam, for asking this question. First of all, I would like to say thanks to Rahul for taking a very extensive presentation. And in fact, many of the drugs, I heard it for the first time. Let me acknowledge this fact.
Yeah,
so I was not even
too.
aware of this. So that is one part. So thank you, Rahul, for adding a lot of things to my dictionary. See, Ghanshyam, as far as your question is considered, I have a different perspective because see, 80% of the cases, anyhow, they're bound to recover. So we have to understand this fact. So whether you're exposing, this risk of all this kind of medication to this subset of population, whether it's actually viable or it's actually genuine or not, it's something we really need to see. Now, as far as, the requirement of this medication is considered, see, we have been lucky because by the time we receive the patient as an intensive care, the consultant, most of this medication, they are actually out from, the treatment protocol. So there is a huge difference between what, the internist is going to see versus, the intensive care specialist is going to see. So that is the one thing. But having said so, in case if I find my patient who is on, all this kind of a medication, especially, the HCQ and all, I generally take the, the opportunity to, omit, all this kind of a medication. There is a reason why. See, half of the times, the patient develop the side effects and we fail to understand whether the patient is actually having a progression of the disease, which is leading to this kind of a sign and symptoms, or is it related to the side effects which are related to this medications. So by and large, I was never convinced. We have never exposed our patient to this kind of medications. Although I agree, Dr. Atul has said that majority of us has, used all this kind of medication. But fortunately, I never had, that kind of an intention to use in any of my patients. And, we feel confident about not using this medication for, the majority of the cases.
Dr. Kunal, welcome.
There is one more point, Ghanshyam, I would like to address. See, Rahul has said that probably, all these drugs, they have immunomodulation property as well. I'm not very, very sure whether the immunomodulation would be required so early into the part of the disease of illness. So, all this kind of a conjectures or, this kind of a thoughts, they are basically, I think, they're more or less dependent upon your own interest and, your own thought process rather than, something which is proven beyond, So I think it's more of, the user comfort. And as Dr. Naval has said, that sometime, we are in the peer pressure to, to give something to give so that, there has to be something onto the prescription, basically. So
Manish,
from that,
let me admit this. There are a lot of times I have prescribed ivermectin for the simple reason that family, friends call. They don't want to go to the hospital. They want something, and they keep calling me continuously. And so they say, please take this. And they're happy, you're happy. But I'll just tell you this, Manish. The lot of patients whom I prescribe this, probably because of logistic reasons. There were some of the high-risk patients who could not come to the hospital. What I have observed is none of them actually needed to come to the hospital. Now, whether it was the ivermectin which worked or was it their natural defense mechanisms which worked, well, as I said, it's going to be difficult to prove that, right?
Yeah,
Dr. Kunal, your thoughts on the whole thing, ivermectin and hydroxychloroquine.
Thank you. And it was an excellent presentation. It was a wonderful presentation. I agree with all your comments about, how we have evolved in, I have prescribed hydroxychloroquine when we started this in March last year, I think March, April, mostly in the hospital. And ivermectin, not so much that we have prescribed here, to be honest. But I think I'll just add to what you guys have commented because essentially what it comes down to in the current situation in India is it is hard to do nothing. And it is hard for the patients to accept that it's okay to do nothing for the first 5 to 6 days. That is the basic fundamental problem. And what it creates is that unnecessary anxiety and chaos. That, oh, my family's taking this, or somebody else is taking this, can I have the same thing? Now, to be honest, if you ask me, that anxiety and fear is created, that is probably directly proportional to how your immune system is going to get dysregulated in the next 5 to 7 days. So I think it's a very tricky situation, to be honest. And one of the things which would be helpful in this situation, if we have a standardized approach. If we have a standardized approach and say, look, we're going to go by what's the evidence. Initially, in the course of COVID, yes, we were trying different things because we were trying to figure out how to handle this situation. Now we have so many trials, so many studies telling us what truly works and what is still questionable. So if we have those data, then it has to be a standardized approach and say, hey, look, this is, I know you are concerned, but this has not shown any benefit and it might hurt you. Because it comes down to first do no harm. So many of these things we sometimes are cornered to prescribe might end up hurting the patients. And it might help to explain that, look, yes, hydroxychloroquine has not shown any benefit. It might hurt you. So please, be careful with that. That might help.
I think HCQS is most of us do agree that, none of us are prescribing or either as a prophylactic or as a therapy for COVID-19. Ivermectin, I still see a lot of prescriptions. I think there's still, people are going to prescribe that. Another molecule which has been very, very popular, on an outpatient basis has been the favipiravir. Your thoughts, Dr. Nawal?
Again,
what scares me about favipiravir is taking 9 capsules at one time on day one, morning and evening. It's huge. Nawal, your thoughts?
Yeah, so Ghanshyam, what we did was at our institute NIMS, we did formulate some guidelines where and how to use favipiravir. But as when we redid the guidelines this year, actually they don't figure in the guidelines anymore. So as what we all are talking, the molecules are evolving when we first started treating COVID and now when we are treating. But I would just mention about the dosing of this molecule. Definitely, it was pinching when you had to take those 9 tablets first day, morning and evening. But over the next few months, now we have about a 400 and 800 milligram option 2. So that definitely has reduced that much of pill burden for the patients. But yes, it's a plus minus situation again with favipiravir. But one good study which had come out from Bombay, Zareed Udwadia had come out with that trial. I'm sure all of you are aware it was a multi-center trial where he demonstrated the use of favipiravir and he showed that it was statistically significant where a patient went from being mildly symptomatic to asymptomatic and recovering faster. And that probably pushed the use of favipiravir a very big way all over. So we did follow that, for quite a few months, and we even continue to follow that on and off. But as such, I don't have much of usage of this molecule in our guidelines. I'm sure other panelists may opt for any other options.
Dr. Atul, your thoughts on favipiravir?
Yeah, Dr. Ghanshyam, I thought you had a perfect patient selection with ivermectin and everybody recovered at home, but probably I had a wrong patient selection with favipiravir initially. Whoever I prescribed landed up in the hospital. So maybe the patient selection was wrong from my side. But as was rightly highlighted by Dr. Nawal, apart from the data showing, 2 days of less, disease-free, symptom-free with the favipiravir, which was by the Udwadia group, So that, and probably this was the only antiviral touted available in the market. So probably that is why it picked up. Otherwise, there is no strong evidence or data to show any benefit out of it. But probably this was only labeled as the only oral antiviral. So it caught up actually. You see the scientific data, there is hardly any to support its usage for any benefit. But then again, early days, we don't have much drugs, so you have to use something. So this was probably better than HCQS in the way that it was labeled as an antiviral. So that thought came in everybody's mind, the clinicians as well as the patients, that probably yes, it may show some benefit. But I personally feel that it's not a very good drug, and there is not strong scientific data to back it up.
There is a Indian Journal of Infectious Disease one paper by Dr. Shashank Joshi and a lot of other people. They have actually pulled a lot of clinical trials also, and then they have seen that a lot of countries are still using it and approving it for the use of COVID-19. So still, I'm not strictly for or against favipiravir again. Then we don't have. Then we really don't have anything in the initial stages for the patient. In fact, some of my patients become happy that there are 9 tablets given morning, night for me for COVID-19. That probably will be helpful. Some extraordinary thing has been given to me, like 9 tablets morning. You are sure 18 tablets a day? Yeah, 18 tablets. And then followed by say about 8 tablets per day again for the next 4 days. They have that thing or something abnormal, the extraordinary has been given to me, some Sanjeevani Booty. But what I have gone through in the journey of making this particular paper or presentation is one that particular Indian Journal of Infectious Disease thing by Dr. Shashank Joshi, and the conclusion was that you can use it.
Dr. Rahul,
you can.
Yeah.
Dr. Atul, please go ahead.
Please go ahead, Dr. Naval.
Sorry. So I was just trying to give a small situation to everyone, whether at particular situation can we still consider. You have a mildly symptomatic patient. Well, in just 2 days of illness, RT-PCR comes positive, and he's got risk factors of hypertension, diabetes, coronary artery disease, or something. And what we follow is do a baseline complete hemogram and a LFT. When LFT comes normal and the hemogram shows a high NL ratio. Now, high NL ratio, we all know, are linked to situations where we have seen disease progression going on. So would you consider starting antivirals such as favipiravir at this stage? Probably he's into just day 2 or day 3 of his onset of illness. I mean, this is probably one situation where I would think, I don't know, but plus minus, as I said, I would say plus minus whether I would start. Again, a question to everyone, or any comments from anyone.
I think the answer by most of them would be they would err on the side of starting rather than not.
That is a viremic phase, I believe, sir. When there is viremia, then only you will have fever, body pain, joint pains, myalgias, and all that. Once the viremic phase is gone and then the dysregulation phase has started, you have lost that bus. So you don't have anything else. I am not again categorically telling that I love favipiravir, but is there anything else other than that as of now, other than monoclonal antibodies that have come in the market for same situation, what you said?
But again, Rahul, if you look at when you're talking about a lot of other interventions, for example, whether it's monoclonal antibodies, remdesivir, most of the things have shown benefit in milder cases.
Early disease,
the same argument that we put forth to interventions like, say, ivermectin or any other intervention, saying that if it was in milder cases, they would have got better by their own immunity. The same can be, kind of extrapolated to a lot of other interventions in COVID, because none of the therapies except for steroids or oxygen supplementation and to some extent anticoagulation have actually shown to be of benefit in the severe intensive care population. Yes, good intensive care does matter irrespective of the disease, but the same discussion can be argument can be put forth. So I was actually going to extend that case scenario, Dr. Naval, to Manish, because we deal with intensive care patients. Manish, do you think remdesivir is the magic bullet?
See, first of all, do I have the liberty for answering about the favipiravir?
Yeah, please.
See.
We love your counterpoints.
No, it's not about, the counterpoints, Ghanshyam. The main thing is that I still believe that, making a cocktail is not the solution for that given situation. So rather than, focusing on, all this kind of medications, which has been always, I do agree that something has to be done. But why don't we, understand the situation into this perspective that, the person has to be, as, Kunal has very well said, that somebody has to spend the time with the family, the patient. You have to make them understand that these all medications, they are likely to, create problems as well. And, I don't remember, Ghanshyam, not even a single patient who came to me for teleconsultation and I have given, favipiravir for this thing. Yes, I do have given, those 15-20 minutes extra for, the consultation to make them understand. And by and large, all this kind of cases, they have been able to survive. And at the same time, Ghanshyam, we all need to understand 80% of the cases, they are anyhow bound to recover. So, why we are hitting, all them with, all this kind of alternative therapies when, they anyhow, they are supposed to recover by on its own.
The problem is, Manish, you will not know whether the patient that is coming to you falls in an 80% or the 20% category.
This is what I'm saying. See, if the person is falling into that 80% of the category, so they are anyhow bound to recover. Now, when it comes to the translation of the patient from mild to moderate disease or the severe illness, anyhow, they are not going to be effective. So let's not complicate, the stuff. The things are very simple for us to understand. It's just that because we are having a lot of, the emotional vigor at this point of the time because we have lost so many patients. So maybe, it's a chaos which we are having, from deep inside, which is, pushing us for, all this kind of medications. Now, coming on to the second part, Ghanshyam, you asked me about use of remdesivir for, the patients who are coming to ICU. See, Ghanshyam, by and large, the patients when we receive, they are already receiving the remdesivir. So there's no other option apart from, continuing this medications as far as, my role as an intensive care person is concerned. It will be started by the emergency medical person or, the internist or somebody. But as far as, the patient outcome is considered, when it comes to the solely remdesivir, I'm not convinced, I'm not convinced because we fail to understand, how does it's working and all. I do understand, yes, it looks good, especially if you're combining it as a bundle of care where you're doing all of the good things together apart from, the steroids and, taking care of good critical care practices. But as a sole therapy, for the patient who are there onto the mechanical ventilation and all, I don't think, it is making any difference to us.
I agree with that part, Manish, and I want an opinion from the rest of the panel because there was a time period in a month back or so where there was severe shortage of remdesivir.
Yeah.
And there was a time period where a large number of ICU patients did not get it. We had, I mean, it was like, it was not available, you didn't give it, but we didn't find that actually had an impact. There were still patients who were coming out of the ventilator. There were still patients who were surviving the ICU despite not getting the remdesivir. But again, as you said, what other options do we have? I would like to take the opinion of the rest of the panelists there, their opinion upon remdesivir. Would you give it in the wards or would you say that this has to be given only to patients who are on oxygen?
Dr. Atul.
Yeah, Atul.
Yeah, so that is a very, very interesting thing. So we have actually been seeing patients since March, April last year. So there was no remdesivir available in India that time. So as Dr. Ghanshyam has rightly highlighted, that obviously it's not a magic bullet which is going to change things. So we've had a lot of patients in initial half who went onto the ventilator and even came out. We were skeptical of using steroids also that time because the recovery trial was not there. So we were using steroid off and on with, a lot of caution that time, and we could salvage a whole lot of patients then. So saying that remdesivir would actually make a whole lot of a difference, I won't agree to that. Then using remdesivir, we all know it's an antiviral drug. Dr. Rahul has already highlighted, and we all understand that the window is, so the timing of the drug is important. So by the time most of the patients would land up in Dr. Manish's ICU, would be 10 days, 15 days, 20 days down the line. Remdesivir that time would hardly make any difference, or probably none, for what I believe, will make any difference in those subset of patients who are already, second week, third week. Because ICU, very, very rarely you would see a patient landing up in the ICU in the first week. It will be very unfortunate and unusual. It may happen, but generally it will be second week, third week, because most of the patients, two reasons for them landing up in the ICU late. One, shortage of beds. So all your patients, especially in my hospital, we have had in the second wave patients with 15 liters, 16 liters with BiPAPs on the ward only. So by the time they are ending up landing in the ICUs, anyways, it's pretty late. So remdesivir would. Remdesivir usage, I agree, and I personally feel, and whatever data I have reviewed and what Dr. Rahul has highlighted today, if you give it up early, that is, moderate patients upfront, initial 5-7 days, 10 days of illness, there is definitely a difference in the length of stay. There is fewer defervescence happens, and there is betterment in these patients if used up early. But as using them late, 10 days, 12 days, 14 days, it will not make. Then using it for, some people are wanting to use it for 7 days for some reason, I don't know. I've seen people using it for 7 days. Whatever data I have seen is 5 days and 10 days. And usually I've used it for 5 days. Yeah, 10 days patients who went on from the ward to the ICU, and they've, continued it for 10 days on those set of patients. But 5 days is good enough. And Dr. Rahul had initially asked whether we can give it for 3 days also. There was a question from him during the debate. So I feel the patient, the general guideline is that the patient has to be off oxygen and symptom free for 3 days. That is the usual guideline which we follow in this part of the country. So I think 5 days would be judicious enough. We should give whatever data we have is for 5 days. So at least 5 days we should give once we have started. 3 days would be a short duration. So that's what I would feel.
This is the question that was there
7
in the
to 14 days. The 7 and 14 days is kind of, the 7 to 14 days duration is kind of inbred into our minds. We generally tend to put the antibiotics for 7 days or 2 weeks. So probably that is what where the 7 days is coming. Rahul,
so this question of whether or not we can stop a remdesivir at the 4th day if the patient is good enough is there in the query of WHO protocol. In fact, they have told that if the patient is absolutely all right and the patient is fit enough for the discharge and it is the 4th day only of remdesivir, you need not continue. You can still send him.
But generally what is happening is patients who are on oxygen and all are getting remdesivir. Generally, that is what is happening. So generally in 2-3 days, they would not be fit enough to be going home. Generally, that's what it is. Very few high-risk patients and mild patients are getting it. Definitely, there are people who are getting it. So maybe they are giving remdesivir is again questionable. We have reviewed literature recently. We have seen certain, doctors, health professionals, immune compromised patients, where they have seen that viremia may be long, and we have given remdesivir a second course also. So I don't know how justified we've been there, but we have done that. 5 days initially and 5 days again thereafter. I don't know how, but because it was a doctor and he took out the paper for me and gave the paper that you should try it. So we've tried that, but obviously those are anecdotal cases and special situations where you may do these kind of things, but it is only to be given in those cases, moderate cases.
Dr. Kunal, Dr. Naval, your thoughts?
I mean, I agree. I mean, Atul's quite well summed it up. I think, firstly, it's not a wonder molecule. What went wrong in our country is we didn't know how to position it. Neither did we give very, very good clear-cut guidelines to the masses where to use it. anyone, everyone just assumed that every other patient needs to go on remdesivir. And that's what triggered the whole alarm on the lack of molecules available. They going in the black market for 60, 80 grams a molecule. I mean, it was ridiculous. See what happened. After that, AIMS guidelines, they took it off. They put it only for special situations where they kept it for people who only require oxygen, moderate patients requiring oxygen. The Ministry of Health also said there is no role. And see what happened overnight. Next few days, now you've got remdesivir available. So it's probably we are also to blame to carry down a message to everyone, probably the wrong usage of this molecule with wrong situations and all. So this has gone to the general practitioners. It's gone into the hands of everyone possible, and they have used it left, right. And that's where, this is the reason for all this kind of situation we are in now. But as long as NIMS, when we formulated the guidelines, where we place remdesivir is exactly mild, moderate, severe. When we come to moderate, minus hypoxia, that is, we label it as 2A, and with hypoxia 2B. We start remdesivir in 2A. We don't wait for the hypoxia to set in, because we see, as very rightly pointed out by Atul and Dr. Manish also, probably, we realize that the duration of hospital stay is reduced. We have salvaged a whole lot of our own colleagues, my own colleagues, who have come in situations where they have got a CT severity of 8, 10 or 14 on 25. They're just around 94, 95 on their saturations. And we are not going to wait for that magic figure of 94 as what they mentioned. We would rather start it at that stage, and we are having good results. So I think a lot of it is, whose hands this molecule is given to. Unfortunately, it's gone into the, people's hand. I mean, it's gone into everyone's hands, and it's been misused so badly over the last 3 to 6 months that we are all to be blamed right now.
I totally agree with you, Dr. Nawal. I mean, when there was a shortage of remdesivir, families would get remdesivir out of their pocket, saying, "I have got it. You load it in front of my eyes, give it." Because I want to be sure that whatever while I have got it, it goes to my patient rather than somebody else. Dr. Kunal, your thoughts?
Nawal sir, Kunal sir, I wanted to ask you this question. There is a clinical scenario that happened today itself in the morning. This guy is a 48-year gentleman. He is a diabetic on 3 different anti-diabetics. Just as Dr. Nawal said, his saturations were 95 to 96 around. But the lungs showed significant involvement, and there were early GGOs. It's still consolidation was not settled in. He is in his correct 8th day of fever today, still febrile. In fact, has started developing little breathlessness, but without hypoxia. And he is to be offered a treatment. Remdesivir alone, monoclonal antibodies alone, or both remdesivir and monoclonal antibodies?
So I think so. The monoclonal antibodies we have seen, we have used in much earlier than after 7 days. We have used much earlier because once that inflammatory response sets in, that's when you start getting into this lung inflammations and hypoxemia following that. So if you're going to use monoclonal antibodies, you want to use it early. Remdesivir, it's plus or minus. I think I would still use it in the scenario that you just said, because as Dr. Nawal pointed out, I mean, essentially it's a disease of immune dysregulation is how I see it. That's why it's like a biphasic illness, right? Because initially you have this viremia, you have viral replications, and then it depends on how individual immune system reacts to that. More immune dysregulation, more dysregulated cytokine balance happens. And that creates this whole problem. So if you're going to use something which is an antiviral, which is not going to kill the virus, it's going to reduce the replication of virus. You want to give it early. Because if you reduce the replication of virus early, the less chance theoretically you would have for immune system to get dysregulated, because if you reduce the viral load, I think the immune system is going to feel much better to handle what's left. So in the scenario just you had, yeah, would I give remdesivir? Yes, I would give it remdesivir, because especially if it's
since you mentioned about the monoclonal antibodies, your thoughts on that? Because again, this has now become the next craze, right? This has become the next, the most sought out therapy, where everybody's announcing that we have the monoclonal antibodies. Your thoughts on that?
So monoclonal antibodies, we have used it here mostly, and that's the only infusion we have used in an outpatient setting.
So if you have to pick up your patients for monoclonal antibodies, who would they be?
So for monoclonal antibody, what we would do is, okay, many of these criterias are designed based on supply demand. What's available and what your needs are, right? So, but in general, if you're going to give a priority to somebody, you want to give priority to somebody who has higher chance of developing a severe disease, depending on the age or comorbidities and all those other risk factors that we know. So that's what we would focus on the first. But at the same time, if you have that's how we started here with monoclonal antibodies. Said this is the only criteria that we're going to use. We still avoided very mild disease, where if they don't have, many of these patients we have seen, they're asymptomatic pretty much. They don't have anything. They're positive, but they're completely fine. We kind of avoided those. But if they have symptoms, fever and upper respiratory tract symptoms, whatever that is, and if they have those risk factors, that would be the first priority for monoclonal antibodies. And then if you have drug available, then you want to go to the next phase where you want to still give it to the younger patients if they are significantly symptomatic, yes. But if somebody is in 20s and 25, but they are asymptomatic positive, you probably don't want to use that.
Dr. Ghanshyam, actually NIH has released a set of guidelines where exactly these monoclonal antibodies are to be used, and they have mentioned in mild to moderate disease with certain issues like people above 60 years, people who are morbidly obese, people who are having high risk factors like uncontrolled diabetes, hypertension, and then immunosuppressive patients and so forth. So they have listed out a group of, or a select group of people right now where they say that this is where probably the usage of these are to be initiated as of now. I don't, as what Dr. Manish says, it may extend. I mean, as Dr. Kunal says, it may extend further. But right now, they've formulated certain areas of usage.
So the question that I have is, see, most of these higher risk group people are vaccinated as priority. So most of them would have had an antibody response. And if you look at the trial, they have suggested that if the patient has antibodies, then the probability that the monoclonal antibodies are going to decrease your viral load comes down, right? So are we going to be in a situation where we are going to see a large number of the people who are at high risk, who have been vaccinated, getting an infection, coming? You are in a catch-2 situation whether you give or you don't give, because they fit the criteria that they are at a high risk group. They have a potential for landing up with severe disease, but they are also probably vaccinated, so they might be having an antibodies. Whether the 60,000 drug, would it work or not? I mean, any thoughts on that, Dr. Atul, Dr. Kunal, Manish?
I think Ghanshyam, if I have to just take the opportunity to speak over this, why don't you get the antibodies level done and decide accordingly? So take the antibodies into the assessment if you want to decide on the basis of antibodies.
One thing I would suggest is that in case you are not able to do an antibodies, we know that with the age, the antibody response also diminishes. If suppose somebody has got a immune, say, compromise, and they have been prioritized to get vaccinated, we will take it theoretically, if it is possible, that they have not that robust antibody response to the vaccine, and then still go ahead and give that monoclonal antibodies if they are requiring so. So.
Yeah.
One question about
that's way of looking at it, yeah.
Again, a lot of things are
Dr. Atul, your thoughts on that?
Yeah, I am very, very impressed by the monoclonal antibody thing. Anything which is expensive is good. So if you offer somebody plasma, that's not good. He has to run around for that. This is good. So a lot of people are right now, my hospital has got these stocks. They are also telling me, start using it. So I'm looking I've offered it to 2 patients. They are happy. They are saying, if you say, we'll give it. But I myself a little jittery as to give it or not. So, but as theoretically and from whatever we understand, definitely if we give it in first 5-7 days, that is a time probably we would have advantage, whatever theoretical advantage it would be, because you have these preformed antibodies and you may be able to mount a response against the virus which is inside. So that cost is a factor, because then it adds to the value, because a lot of patients must be coming to all the critical care experts and other people. If their patients are admitted in the ICUs and if they are not getting a high-end drug like a tocilizumab or a JAK2 or something, they feel they're missing out on something. Their doctor is not offering them this. So I had a patient, very, very interesting. Most of you must have seen these stories. This guy comes up with a summary that patient is admitted in so and so hospital, and you name the drug and that patient had actually got it, and the only drug which was left was a tocilizumab, and he said, okay, I have given the consent for that also today, this morning, and should I give that or not? So it's crazy. Actually, it is crazy, but that's the way it is. It's everybody is very, very disturbed, and there is so much information on the social media and the media which is causing a lot of confusion. But antibody, yes, antibody test, as they are saying, but I don't think so. I have not seen anybody mount an antibody response in 5 days. So you can do a test, that's all right, but within 5 days, 6 days, any healthy person also generally would not mount a good response, antibody response. So you have that window, rightly as highlighted, 10 days, 8 days, 12 days down the line, there is no point of using the drug. So it is basically the timing of the drug which is important. As Dr. Nawal also highlighted, that it is the placement of the drug, who is using, when to use, not to use everything in every patient, or that is what is happening right now. Every patient is getting everything. Within a week, this patient story which I'm telling, he is in the hospital for 10 days, and within 10 days, he's got this everything. So I am actually not, sure what's happening. The timing is very important, which drug to be given.
Totally go with you, Dr. Atul. The important thing, again, we need to realize that we are placing it as an outpatient molecule. We are trying to say, you come take the molecule and go. So if you are going to leave it to anyone and everyone for, as an outpatient molecule, it's going to go the remdesivir way. I'm telling you, I think it has to be institutionalized. There have to be certain signatory bodies to this before the molecule is given. It has to be placed in the right hands right away. This is going to go into the market. It's going to be mayhem. It's not about 60,000. Everyone will put 1 lakh rupees to get this molecule.
I totally agree with Dr. Nawal, because one of my friends sent a prescription of this and said, this is available for 1.6 lakhs. What do you say? I think we need to have a clear understanding, a clear regulation about where this molecule has to be placed, who has to prescribe. Just like today, tocilizumab in Telangana, if at all it has to be given, it has to be given through an approval by the committee from the government body, where you describe the clinical condition of the patient, put up all the investigations, and then the DME decides, yes, whether it has to be released or not. I totally agree with you that we need to have something like this. Now, coming to another very, very important part, role of antibiotics. We all say there is no role, but if you look at every prescription, there is an antibiotic.
Yeah, it's unfortunate. It's unfortunate. Rahul highlighted so much that there is no role, no guidelines mentioned. There is nothing about role of antibiotics in treating COVID, actually. These are areas probably Dr. Manish should highlight a lot more. These are used probably in those situations where they are already in some sort of moderate to severe, they're in an ICU setup, there are protocols in place where some prophylactic antibiotics to be used, or they develop ICU related some sort of infections coming in, and so forth. So otherwise there's no real role of mentioning anything about antibiotics in COVID for mild cases, or even for that matter, moderate. I'm sure all of us would do, we all do our procals from time to time. We take the clinical picture in total context of the patient from time to time. We see those patients who are running high fevers into 6 days, 7 days, whether there's associated bacterial infection or it's part of the viremia which is causing this. So I think it lies in the hands of the clinician more so once a patient goes up the ladder versus in the hands of the intensivist.
Manish, your thoughts. Sick patient coming from the wards, WBC counts can go up. He is on steroids. There is some amount of tachycardia, hypotension. Your take. Would you
Yes.
give the benefit of doubt, or would you say just hold on? This is
Yeah,
all because of COVID.
I will give the benefit of doubt, but I will not expose them to antibiotics, honestly. So the most important thing, the Ghanshyam, which you have asked, that, see, by and large, we all have to agree that the patient should not be exposed to the antibiotics in the first 7 days of illness. So if the patient is really lucky and you're receiving the patient early in the course, there's a difference between when you receive the need patient versus the patient who has been referred from somebody else. So if you're receiving a need patient, which is uncontaminated, not having any indwelling catheters, not indwelling devices or any stuff, the first 7 days, they're very important because they are just, it's going to be viremia. You just have to sit on to the patient, be a good thorough, the clinician over them, do the basic things into the best possible manner. And, once you find that the patient is having some oxygenation deficit in the form of your assessment, then the patient will need some, the doses of steroid. That's it. Now, the question comes, let's say the patient, as you are talking about, the patient is having a steep rise in your oxygen requirement. The patient looks, toxic and all. See, by and large, a person who is having this kind of a picture in the first week of illness, it has to be a cytokine release syndrome. We all need to understand, this is a one disease, which is most of the time it is present as a single organ dysfunction. I'm talking about the initial need presentation, right? So it comes as a single organ dysfunction. They are most of the time hemodynamically stable. And by and large, the reason for their, the decompensation is purely pulmonary, for which they are coming. I do agree that they do have affected, the other multi-organ, the involvement as well in the form of liver function and all stuff. But by and large, the main reason which is leading to their morbidity and mortality is the refractory hypoxemia, right? Now, when this is a scenario and you are bound to give this patient, the rescue doses of the steroids versus, the tocilizumab, depending upon, the institution to institutional practice. Now, there comes the catch. Once your patient goes into the second week of illness, receive 3, 4, 5 doses of pulse steroid, the patient has been started on, the 2 doses of tocilizumab, then comes the catch. Now, at this point of a time, when you're already there in the fortnight and you find that the patient has all exposed risk factors to get into the contamination zone, and plus your patient is carrying all, the in situ devices, like, the Foley's catheter, the lines and all things, where the high likelihood of, the cross-contamination, giving the infection from one patient to the second patient. In this situation, yes, they need to be on some sort of an antibiotics. So what we are doing is generally that we give them a broad spectrum, the beta-lactam. Most of the time, the ceftriaxone, sulbactam, or a piperacin-tazobactam in combination with a good gram-positive cover-up has to be done. We saw the slides which, the Rahul has shown us, especially we have to understand that, the viral pneumonia per se, they have a strong predisposition for MRSA bugs as well. So you will find them, carrying a MRSA infection in the chest. So these are the 2 most important things which we do for them. As far as, the de-escalation protocol and all kind of, the duration is considered, by and large, 5 to 7 days does justice to them. If your patient is not settling on this and you're requiring some accelerated doses of, the carbapenems or, your tigecyclines and all those kind of, the polymyxins, generally they don't survive very well. So, unless and until your strategy is very, very clear from the very first, Now, this is a lucky scenario when you're receiving a patient neat, which, we should try to. When it comes to the second-hand patient, where, the person has already been contaminated from, the outside segment, there will be a catch. You will get into a trouble. And that's why, these are the cases which are dying. They have the highest mortality burden. Devising some kind of, the antibiotic stewardship program for them, it will be very, very difficult. So it has to be seen on case-to-case basis. But yes, what we are doing for these kind of cases and the transplant settings as well, we make sure that, all the invasive, the catheters and devices, which actually serve as majority of time, the source of infection, they need to be periodically changed, or they need to be on high surveillance as far as their, the possibility of carrying, the infection source is considered, whether it's a CLABSI or CRBSI or the VAP or, the potty. So all those kind of bundles, they need to be rigorously practiced. But prophylactic antibiotics, just because the patient is sick, is something which we are not doing it. And we are confident about it. Yes, it makes a difference to, our patients.
Dr. Atul, your thoughts?
Yeah, actually, Dr. Manish has already summed up what we all of us actually feel the same, I think. But as we've said that for all the other therapies, we have the patients and the media to blame. For antibiotics, it's us clinicians to blame. So we all have to take the blame, because these are not, we are not pushed for this. We all are using it for our own safety and of own security of or insecurities we all have, that the patient is immunocompromised or patient is this, and we are giving him high dose steroid, so we should give an antibiotic. We have to refrain from this. This is very important, because there is no role of antibiotics in this. And as I was say that hardly anybody has had secondary infections in the initial 7 to 10 days. Only the prolonged stay in the hospital, and as rightly highlighted, is the lines and the catheters. So you would see UTIs or thrombophlebitis or a line-related sepsis would be there, rather than, any other infections in these patients. Well, WAP and all would happen if, the patient is on a ventilator and staying in the ICU for a long period. That's known to happen in all settings. So it is very, very important for us. We all say so, but when it comes to practice, we all become very this thing as to let's give at least something. That is a feeling which we have to refrain. Antibiotic use upfront without any evidence, as Dr. Nawal said, we are all doing cultures, we are doing all procalcitonins, we are looking at the patients clinically. So whenever there is evidence, why not? It's always available. Antibiotics are not in short supply, they are there. We can use them anytime, It's just the antiviral is in short supply and the other drugs are. So we can, so it is for us to decide and, make a policy as our institute or whatever, that we should not be using anything unless and until it is really essential.
Just another question. Do you think that there is an increased risk of secondary infections, considering the fact that the workload has gone up, the number of, the kind of nursing, the ratios have been compromised, the sheer fatigue setting in, probably the, compromising on the various bundles? What is your general observation?
Well, I think that will affect anyways if you're not able to follow the hospital control guidelines, the policies of the hospital, the hand washing and the hygiene and the all the bundle infection control bundles which are in place already, then obviously the infection risk would go up. And obviously there is this kind of fatigue, mental as well as physical, set in the healthcare workers, which sometimes I would feel, yes, that would add sometimes, because sometimes you tend to, you're using gloves, the nursing staff, and they may not change. They're touching one patient and the next, they are overworked. The ratios are disturbed, as you said. So that, but for that, you can't do much. You have to just reinforce your staff. They are aware of it, but then in those difficult times when they are overworked, they are seeing so many patients, your resident staff is there, so they tend to forget or, get tired and, doing this. So it's basically education, and reinforcement that we should follow these guidelines is what we can do actually. Yeah.
Yeah, I agree totally.
See,
Atul sir.
Ghanshyam,
Atul
yeah.
sir.
Yeah. Manish, you have some.
Yeah.
Manish.
See, I just wanted to say, because Dr. Atul has rightly said, but what we have experienced, Ghanshyam, that as long as you can keep them off from any invasive stuff, by and large, especially for mild to moderate cases, the chances of falling them up for the sepsis, significant sepsis, which I'm talking about, would be very less. See, all this kind of the turbulence happens to the one segment of population which are moderately to the severe category. So you cannot do all this kind of things maybe for them, because they will be requiring that kind of stuff, the monitoring, invasive monitoring, and the indwelling catheters. But for mild to moderate cases, if you can refrain them from all this kind of invasive things, by and large, they will be taken safe. And another thing is that it is very rare. I'm telling you, Ghanshyam, I receive so many patients in the ICU in the Indian settings, which I'm talking about, the Jaipur segment and all. First 14 days, they are not carrying any sepsis.
I agree.
So do not hit them, with the antimicrobials. If you want to give them, your antiviral, which everybody has a consensus. Although I don't agree for that segment also, but don't hit them, And so there is no confusion about it. And if you are just see, a lot of times there is a pressure also, the peer pressure which comes. Let's say I'm sending a patient to the Gangara. If I don't do it, it will receive the patient. Somebody will add it onto some other stuff, and Dr. Atul will agree to this part. So,
Yes.
so that is another problem. So as very well said by Dr. Naval and Dr. Atul, it's a moral responsibility that everybody has to understand. This antibiotic stewardship should not be there on the paper only. It has to be practiced. It has to be religiously, it has to be understood. And burden in this kind of cases which are dying late is mainly because of bacterial sepsis, and all because of this bad policies which has been given in the first, the 2 weeks.
Rahul, you were saying something?
Yeah. I was trying to steer out from antibiotics to that गरीबों का क्या बोलते हैं monoclonal antibodies 2DG. Your thoughts?
I really don't know much about this still. I mean,
Rahul is always taking thoughts about the things which I have not even seen. I don't know.
We have just started it.
Actually,
and
what's
it is
happening
going
with
to
us is,
become a big thing.
see, the same thing. Now patients are coming day 14, day 15, day 16. Patients' families are getting the packets and saying, why don't you try it?
Unfortunately, one of the patients on the 22nd day, they got a 2DG. The CT scan shows 25/25 involvement. She stood up. She's on 4 liters, and they are all pointing the God as 2DG. And they are pointing like, yes, we got that packet, and now she still two doses, and now she's got up. God only knows what went good or bad on her.
But don't you think, Rahul, somewhere I feel that a lot of things are being done just because of the pressure.
Absolutely.
So we need to understand. So we need to understand.
It is not my case.
No,
and it is in the ward.
Yeah, that's why I'm saying. As
like
Manish, you are not in the Telangana and the Telugu belt. Dr. Naval would agree with us. Now there is a very, very popular, herbal medicine which is going on, and that herbal medication has put in the ice.
No.
It is not coronal. There is one guy who is giving a herbal concoction which has to be put into the ice. You do not know the kind of pressure the family puts us on giving that.
40,000 people landed up. 40,000 people landed up for that. And it's got helter-skelter. I'm sure, I don't know how many super spreaders or whatever would we be seeing, but very unfortunate. I mean,
can't we get that?
No,
there's
a whole
formula for that. We can start using. Right?
So
we have seen very bad results from it. We have seen bad results from it. People have succumbed. So many people have succumbed.
No, Ghanshyam, what I was trying to say that when you were saying that, in the Telangana, the segment and all, see, first of all, we all have to agree that first we have to understand what is right versus what is wrong.
Yeah.
And then all the effort should be directed toward the right things. Yes, you will have turbulence, you will have problems, you will have, these kind of patients, but by and large, you will be taken care of. The problem happens when you get influenced by, the peer pressure and to the family. And that's why we become the bad doctors. But somewhere, this is a time when we all should understand that what is right versus wrong. First, decide that, what we want to do and what we don't want to do. And then, we should try to push for it.
Yeah, I'm sure, I agree with Dr. Manish. We are going to see a lot more molecules come up every other month, and everyone trying to throw their weight around and saying this is better than that and so forth, so much.
And do you think, with due respect to Dr. Atul and Dr. Nawal, do you think it is going to improve, the patient outcome? It will not. Eventually, everything will boil down to the good, the basic clinical practices which have been given to them since ages.
I brought up 2DG because it was touted as the game changer or something.
This is a problem, who has given this adjectives, the game changer? One of us. So we need to understand, why all this kind of things. No, I'm not saying you, Rahul. I'm saying somebody.
No, not one of us. I'm telling, not one of us. It is how the media is projecting it. That is why I want this particular thing to be in this forum, so that we as doctors agree on something that the media cannot dominate.
I completely agree.
Like this.
I completely,
words like this, sentences like this.
That's how media projects. So today I've given a bite for one of the TV channels for monoclonal antibody. And the question was, is it the new game changer?
Because so you ask, that's why.
That's the way you're asked, is this the game changer? You would say.
Someday they are
I think we have kind of extended the discussion quite extensively. So if I have to just summarize, right? I mean, all of us agree that no role for hydroxychloroquine, right? Mild outpatient basis, yes, we need to prescribe something. Probably ivermectin and favipiravir still goes with a lot of physicians.
Plus,
Manish, you and me, we are from intensive care.
See, Ghanshyam, you yourself is saying because we have to give something that becomes the indication. This is what I'm saying. First, you get convinced yourself whether you think it is going to make a difference. See, let this part to be settled by Dr. Atul and Dr. Nawal. They are the best person.
It is their headache. Dr. Atul, Dr. Nawal, and Dr. Rahul have to decide whether they have to give it to their outpatients or not. Definitely, intensive care, you and me are not going to give it.
Apart from scientific, there are other compelling reasons also.
Yes, I agree. As far as remdesivir is concerned, I completely agree with Dr. Nawal that it has to be properly placed. You need to identify which subset of patients gets it. Probably those patients who are in the moderate risk category, having risk factors, where you feel that the inflammatory markers are going up within the window period where you think the antivirals are going to work. Probably those are the subset of patients where we can give. Beyond 10 to 12 days, I agree there is no role, and we should be very upfront with the family, telling them there is probably no role, not to worry too much about that, because patients have survived even in the era where remdesivir was not available. I want to say that all the panelists have been, were uniform in agreeing that no prophylactic antibiotics. Stay away from exposure to antibiotics as much as I can. And yes, these are difficult times. Everybody is fatigued, but we still need to stick to the basics of hand hygiene. Keep reinforcing and reiterating the team that we need to stick to the basics. Thank you, all of you. It was a fantastic discussion. Dr. Atul, fantastic to have you on the board. Dr. Nawal, thank you so much for joining us.
Thank you.
Manish, you have always been there. I'm sure that you will be there with us for the entire journey of the webinar. Always a pleasure to have you. Dr. Kunal, I think he had to go and see some patients. Thank you, Dr. Kunal, Dr. Chandrasekhar, and Rahul, my dear friend. Thank you so much for the extensive review of the literature. Thank you all.
Dr. Rahul and Dr. Ghanshyam, you should add us for all your upcoming programs also. We can.
It will be a pleasure.
You would like to learn.
It's always a learning process. And a very interesting thing today. We are three brothers, and their names are Rahul, Atul, and Nawal. So it's just something, So I'm the youngest. Rahul Bhaiya is the eldest. Atul is the middle one, and I'm.
It looks like a Manmohan Desai movie.
Amar Akbar Anthony's or whatever. Yeah, true.
Okay. Thank you guys.
Thank you so much.
Thank you so much. Stay safe and have a great evening ahead.
Thank you.
Thank you so much.